Or two of the four deputy executive directors you heard about early today in the presentation from Grant. And one of the things we wanted to do today is we often feel like we come to Medicaid directors, we come to the Medicaid fair and you see presentations and they're very good and they have a lot of knowledge and they're very informative, but we don't feel often like we're just answering whatever you want to answer, right? And we get those comments from y'all where you say, I went to the Medicaid fair was good, but you didn't answer my question. So congratulations. Right now is where you're going to get to field your question. Now, I'm old, and I'll tell you your question is foolish if it's foolish. I won't say it's foolish, but I'll be like, wait a minute, guys, is that a question? And we won't know everything. We don't know everything, but we know who to go to get you the answer if we don't. And we're very blessed to have a lot of good resources in the crowd today with us that we asked for as well. Uh-oh, Rebecca, never mind, I got it. Okay, so we got some questions beforehand. So some of y'all submitted questions, which is great. So I want to be able to go through the questions that you submitted that are policy-related questions first, and there were no bad questions. So when a patient is seen in emergency operations, often they have to have many different things done, right, when they present at a hospital. Maybe they have to have a CT scan or an MRI, possibly therapies, and this causes multiple Medicaid requests for authorizations to be obtained for services. This causes providers to have to sometimes bill up to 3 claims or 4 claims and get prior authorizations for different services. The person who sent in this question said, hey, can we not just have one prior authorization that covers everything and one claim submission? So for hospital admissions, we do pay based on a DRG, which is kind of a universal payment. But there are certain things by the federal government associated with reporting and TMSIS, which is the way we report to the federal government what we're paying tax dollars on, that we have to bill separately. So frequently it's not that we want to do separate PAs or cause you to have to submit multiple claims. It's a requirement based on how we have to report out to the federal government. We will 100% take this question back though and see if there are areas in which we're asking for a prior authorization that can't be either bundled into the DRG or bundled into a universal claim. So it's a great question. The next question was, what is the future trajectory of dental coverage under fee-for-service? That's a really good question too. As of last year, we expanded dental coverage to adults. Everybody knows that in the room, right? I hope y'all do. For the first time ever, we started covering dental services for adults. And we just added every single claim that we added for children to adults. That's what we did. So unless it was something that was child-specific that you wouldn't administer to a child. So the future of dental services in Georgia is we now cover everybody. We're hoping to get more providers on board. So that's what we're focused on now for dental coverage, how we can expand the provider network. The next question is, when can we apply for new counties? And I believe that question is related to structured family caregiving and other waiver-related services, because we've definitely been approached by a couple of providers here saying, hey, I'd like to cover new counties in structured family caregiving and in the waivered services, and I'm not allowed to at this time. Where we have a freeze on expansion to counties, that's because the department is undergoing a review of those services. And as soon as that review is done, then we will put out guidance on expansion of counties or applying to become a new provider. But we have to get through that review process first. Unfortunately, right now, I don't have a time frame for that unless somebody in the crowd does. So we don't have a time frame for that right now. I'm good at picking up cues, but it is currently under review. What is the process for obtaining PAs? So I would encourage you guys to go on to the Alliant website. They have a lot of training resources for how to submit a PA, including resources by service. I would also encourage you to review your provider manuals specific to your category of service, because there are instructions in there on how to submit a prior authorization for service. You can also contact your DCH policy representative for that category of service. If you don't know that, you're welcome to email me and I will respond to you. I'll give you my email a little bit later. Or you can call one of the good Gainwell people and they will be able to point you to the resources for submitting a PA. Where do you find fees? Are they the same as Medicaid? So I'm going to guess what that question was, and it's about co-payments, maybe, because those are the fees that the members have to pay. And those are specific to category of service. They are very nominal for the Medicaid program. Nobody pays more than like $5 for a copay. Like, I don't know about you guys, I have Kaiser, and I will pay a lot more than $5 for when I go in to do things as my copay. But the Medicaid fees usually range between 50 cents and $5, and that comes up when you bill. Fee increase. With the cost of supplies, staff, overhead, it's hard to keep contracts with low reimbursement. I say this all the time, and it sometimes gets me in trouble, but like we're as the Medicaid agency, we don't have revenue, right? We don't have money to give you rate increases. Our money comes from tax dollars. I usually say we don't do bake sales and car washes, right? So we don't generate revenue that we can then pass on. It's not like a normal insurance carrier where you can say, well, take less money for Blue Cross Blue Shield and give more money to the providers, because our money for services is designated by the legislature. You can't even fire all of us and pay more of you all, because that money's in a different budget line. It's for administration. It is not for services. So the way you get rate increases is if the legislature backs your rate increase, or if the legislature funds a rate study for your services. Then we have input in that. They'll contact us and say, how much will it cost to increase dental codes by 5%? And we'll say, well, we think it's going to cost this much money. But we don't have just like a pot of money that we're holding on to at the Department of Community Health. We usually have to go back and ask for more tax dollars in the mid-legislative session. I think that's it for mine. Do you want to do yours? And then we'll take questions from the crowd, okay? Does that work, everybody? Thanks for being the late people who are staying with us. Y'all must live in the area and not have to drive back to Atlanta. No, I see people mad and shaking their head at me right now, so we better talk quick, Rebecca.
Good afternoon, everyone. I am Rebecca Duggar. As Brian introduced, the Deputy Executive Medicaid Director for Enrollment and Eligibility. I had a few questions that were kind of categorized under my space. They were just kind of high-level topics, but the first one was new provider enrollment, credentialing, and auditing. I do have with me here the Director of Provider Enrollment, Leslie Austin, but I will also say that if there are any questions, yeah, woo! Go ahead and get that, woo! If there are any questions related to new provider enrollment, credentialing, what that looks like, what you need to do, you have a lot of resources and tools at your disposal. Not only are the members of the provider enrollment team available to answer questions, but you also have the very capable staff that was introduced earlier this morning, where you can reach out to them, you can talk to them about your application. There's also tools on the website where you can go in, you can look at the websites and the training materials that's on there, and you can follow it at your leisure. So I do encourage everyone to always go out and look at those materials even prior to calling, so that you have the correct vernacular, you have an understanding of the things that you really need to be asking questions about. So that way you can be very thorough in your pursuits there. I had a question here about, will the GT modifier no longer be used? We currently use the GT modifier in our telehealth codes. We have not changed that. If and when we do change the GT modifier in those telehealth codes, you will certainly see that in a banner message, as well as other documentation. We have a telehealth manual as well as the specific service manual. So please look for that information as well. Can DCH correct the EIN information if it was not correct after other documents were sent in? Yes, yes. Please give a call. Let us know what you need to correct. We will help you correct those items on those documents, because we don't want something to be denied and then you have to go through that process of trying to get things corrected or resubmitted, or we have to pull your application. We're more than happy to correct in the process. So please reach out, give us a call in order to do that. Let's see, what else did I have here? No, and that was kind of it for me. There were some things related to service delivery that I know Brian already discussed those. I think we pulled those in. Yep, so we're good. So I think we're now ready to take any questions from the floor. I know we have some folks walking around with microphones. If you wish to be recognized to have your question asked, then please raise your hand and someone will come right to you.
Hey.
So the question again was around the GT modifier. For those of you all who are like, what is she talking about? The GT modifier is actually one of the older modifiers that we use to identify services that could be rendered via telehealth. Of course, after the public health emergency, there were all these other codes that were developed that specified the service, specified the modality in which telehealth services were being rendered. And so they've gradually started to move away from the GT and the GQ modifier. And so we have not changed our code since then. But once we do, and if we do, we will certainly let you all know via those banner messages. And of course, we will give you appropriate time in which to change those things in which you have to change, because we also have to change things in the system as well. Any other questions? Y'all ready to go? Oh, no.
Thank you. So that's a great question. So the question is, so to restate the question, because and y'all, we're not just restating the question to be annoying. We're doing it because we were told to for the purposes of like the presentation, just so y'all know. So the question is, prior authorizations, when someone is made eligible for SSI, specifically in this example, and services have already been rendered under therapy, there's no way to go back and get a prior authorization, right? Do I have it right? Yeah, okay. And there's a lot of reasons behind that. It's often in the name, it's a prior authorization to delivering services, but you can't get a prior authorization if the person is not eligible, right? Oh, okay, so clarification to the question. You had one that was CMO authorized and the child was then made SSI, and then I assume we're recouping. So yeah, so the CMOs are recouping what they have, but we're not able to pay under fee for service. There should be a mechanism for you to do that. So it'll be helpful. I mean, I'm agreeing with you. So, I'm agreeing with you. So that's something we can definitely take a look at. You're welcome to send me specifically those examples, and we'll track to see, one, if there was a PA that was done under the CMO, right? And then see how that can be carried through. Are you a CIS provider or you're a CIS provider? Okay, thanks. That's helpful. We definitely can do that. Have I given you all my email address yet? Oh, that's too bad. Okay, next question. I'm joking. My email address is my first initial and my last name, so it's BDOWD. Again, B is in Brian, DOWD, at DCH, because I work for the Department of Community Health, .GA, because I work for Georgia, .gov, because I work for the government, right? So bdowd at dch.ga.gov. Now, I'm going to tell you something. I get 300 to 500 emails a day, and I am not exaggerating. I can tell you right now, I haven't looked at my emails this afternoon. If I turn on my phone, there's going to be 160 emails on there. So I will respond to you, but if you're like my niece and I don't respond in 5 minutes and then you call, that's an unrealistic expectation. I will try and get back to you, usually within a day, if nothing else, to say, hey, I got your email, and I'm not ignoring you, I'll follow up with you, okay? But for that specific instance, if you can send me some examples, because that's something we need to address through some mechanism. Other questions?
Brian, I have a question. Is there a different system that we can have to require authorization through for a long-acting injection?
I want to say no. No. It's all through the same universal portal, right, Alliant? And
Where is the medication? Where is the medication given? I mean, the facility normal. Okay. So this would have been under dental locations, which would have the appropriate provider.
see, I feel like this is working, y'all. I feel like we're not going to get the email that says y'all didn't answer my question. And that makes me very happy. Yeah, next question. Hey. Okay, you only get one. So pick the most important. Mm-hmm. Okay. Okay,
Medicaid process on Wednesday, and some costs
okay.
for its originating. So I have this proposal, I might be able to get these to you, some detail to see if they can change it to the opportunity for that measure or provision to happen.
So the question is, just to restate, that there are certain codes that are, I was joking about one question. So there were certain codes that are only available to be done inpatient. And would we be willing to look at those codes to see if they're more cost-effective, cheaper to be done out of patient and add that place of service? And absolutely. Guys, there is no day that goes by in my life where one of you do not write me to talk about a code. I have 1 year left working at the Department of Community Health, and sometime I dream of days where no one's talking to me about a code. So we will always look at codes that are not covered under the Medicaid plan and places of service that are not covered under the Medicaid plan. Now, you said something that was really helpful in your pitch, which I love, which is it's going to be cheaper. Because if you just come to me with a random code and say we want to cover this code, we're going to go back to my earlier statement that is we don't do bake sales and we don't do car washes, right? Like, where am I going to get the tax money to cover this new code you want me to cover? So I'll need appropriations for a lot of codes, but if you have a magic it's cheaper, and it really is cheaper, because sometimes people give me it's cheaper and it's not actually cheaper. I'm not saying you, but they'll tell me this will save you money in the long run. And I'm like, the long run like next legislative session or the long run like 45 years from now? Because 45 years from now, save money doesn't help. But if the codes themselves are cheaper outpatient than inpatient, that is definitely something we will absolutely take a look at. Next question.
So, all CEOs talked about your coordination, discussion, risk stratification.
Uh-huh.
I'm assuming now CEOs are on with their payment calculating their level of risk.
I don't do CMO. I'm the fee-for-service guy, so you're out of my range. The question was that in all of the CMO presentations, there were questions about the CMOs doing assessments and categorizing risk based on the clients. And the question was the first part of the question was wanting to make sure that all CMOs can do that. Okay. So let me try and rephrase the question best as I understood. So if the question becomes, so if we are stratifying children for different conditions and there are higher acuity children that need and require more staffing time, has there been a thought at the Department of Community Health to build different rate cells based on said stratification? Correct? Okay, so the question becomes that in that scenario, not even increased rates for children with higher acuity, but is there like a navigator or a case manager to help those individuals and children who would need help based on that acuity factor of being higher acuity, right? Yeah. So that is definitely something we can bring back as well. You can't force case management on people, but it's something that you could maybe offer. Yeah. Yeah. Wait, hold on what you're saying. Go ahead. Thank you. So we had a statement that Leslie Austin is awesome, which I want to say is a lie, and we all know is a lie. Leslie, give that lady her money. And the lady unconvincingly says she was not paid for that comment. Who's next? Leslie is awesome. That's the second time I've heard it today. So just so you know, I had somebody else tell me earlier today, just randomly walked up, and I was like, I don't even supervise Leslie, but we went to the same elementary school, so I feel like it's a Hambrick Hawk moment for both of us. Long live Hambrick Hawks. Education starts early, y'all. Next question? Yeah. So this is a good question, and I'll be happy to let Shanique talk about it too, because I do get this question a lot in fee-for-service, because that's basically what I run, right? My section runs fee-for-service for the most part. Not for all services, but for a lot of services. And we get this question all the time, because we'll operationalize a rate increase or make a change, and then they'll come to us and go, well, now you make the CMOs do it too. And I'm like, I don't even know what's in your contract with the CMOs. Like, you agreed on a contract when you became a provider, and I know a lot of times it references the fee-for-service schedule, right, in your contract. So then we point back to your contract. So to rephrase the question, it was, we are a DCH enrolled provider. And there was a behavioral health rate increase that happened July 1st, 2024. In the last session, we had a mayor group say that they were ready to operationalize that July 1st, 2025, and that they were considering the retroactive period back to July 21st, 2024. That's where it ended. This seems like a follow-up to DCH to say, what you gonna do about it? Do I have it wrong? See? I can translate. I started at DeKalb DFACS. Trust me, I can translate all I need to. So that was the follow-up I got. Oh, good, because we've all heard about how wonderful Leslie Austin is. So now she can prove it.
So I can't understand anything. That liquor was killing me.
Yeah, it's coming too.
You need to repeat the question.
I, I got lost in the question. I don't know if anybody else did. Oh, can you future date? Oh, okay. They can bill under Medicaid, or can they bill under the DBHDD 100% fee for service? And are they being paid through a provider organization? Because what we were saying is you can't be enrolled as an individual practitioner. DBHDD does not enroll individual practitioners. You work for either a core or a specialty agency. And in those arrangements, that's between you and your employer, right? So if I work for Brian Dowd CSB, right, we enroll Brian Dowd CSB and then bill under the requirements that are in category as service 440. But we don't have anything to do with you particularly as an individual practitioner. We only enroll individual practitioners in psychology and therapy program for children under the age of 18. And in that program, we enroll psychologists, psychiatrists, LMFTs, licensed clinical social workers, and licensed professional counselors. That's it. Yeah. So, and I apologize, where's the standard? For which program? But which category of service? So it's a behavioral health requirement for category service 440, community behavioral health? Okay, so, and that's set by the Department of Behavioral Health and Developmental Disabilities? So yeah, it's important. Is it CMO or is it straight Medicaid? Okay, so that's important for folks to know. So, and I know I spoke so let me start from this place. We provide behavioral health services really in 3 places in Medicaid. Category of service 440, which is community behavioral health, right? That's the big package. That's core providers and specialty providers. Core providers are mainly your big CSBs that provide all services. Specialty providers are IFE providers and ACT providers, right? And a couple other things. There's peer support agencies and a couple other things. Those are the 2 type of providers that are in the 440 package. The state match for the 440 package goes to DBHDD for fee-for-service. And they largely drive the policies that are associated with what it takes to bill for those services and who can be an enrolled provider, right? It's just the way we're set up by law in this state. DBHDD is the lead agency for behavioral health services in the state of Georgia, and historically they have got the match for that. Now that doesn't mean that we're not the owner of Medicaid. We are. So when you have a concern like that, my advice for you would be like, this policy is no longer working for us because of COVID, the pandemic, just the way things are today. We feel like there should be additional provider enrollment types or different practitioners in the 440 community behavioral health. You absolutely send that to us, specifically to Michael Smith, who's in the second row right there. He is your point person for community behavioral health. He then brings that back to DBHDD and says, hey, your core or specialty providers has an issue with this policy. Can we talk about it and see how we can change it, right? Now, outside of 440, we provide behavioral health in therapy, psychology and therapy services for children. Those are the individual practitioners I talked about earlier. And we also provide therapy services in children's intervention services and children's intervention school services. And again, those are either school individual practitioners or individual therapy practitioners that are doing therapy. They're not large agencies. And those are 100% owned by us at DCH. So when you have a 440 question, we really need to coordinate it through Michael and DBHDD so we get a combined answer. And that's because DBHDD not only does the fee-for-service Medicaid, but they also do straight 100% state fund not Medicaid, 100% state-funded services for the same services they do for Medicaid members. So when you change the policy, you kind of change it for everything. So we need to be that conduit for you if you're not having those regular conversations with DBHDD. Okay? Thanks, Michael. Michael's really good about contact with DVHDD too. So the question was this: they provided group services. I'm believing you were paid under prepayment per view for not being able to meet the standard that was associated with the policy manual, and they would like that policy to be changed. So that's a little different. So that's something we probably need to get back with program integrity about, so you can write Michael about that and he'll coordinate. Any other questions? Because we were almost done and I was almost driving to Atlanta. But I'm just joking. We got to be here till 3:25 anyway, so we're happy to take your questions. Questions? Concerns? Comments?
I just have a question, it's more of an explanation maybe.
Okay.
So we are every category of CIS, so pediatrics, OT,
Mm-hmm.
and just a question in regards to, when we put in authorization for like CMOs, we are allowed to do like J-tube to tube and the number of units that are allowed after that child has seen. When we do it under, the services, it's the line by line, month by month, so I was just kind of curious as to why for that. So we feel like we run into a lot of situations where if a child has to take someone on 2021, then they pick it up on November 1, they really can't, because then it carries over to their new unit, so now it's a missed opportunity to provide those services. So I guess just some kind of explanation of why it's month by month and not the duration of the period.
Yeah, it's really just the history of billing and how, so the question is, why is there a differential between how we are reporting line claims in CIS as like one bucket for the CMOs as opposed to line by line monthly in the fee-for-service program, correct? Got it right. It's a history of the program and how we report to the federal government. It's one of the good points of the CMOs, right? It's like encounter-based claiming as opposed to individual like reporting when you do it under a fee-for-service model. There are some really good points about CMOs, and one of them is kind of some of the flexibility in the billing that they don't allow you in fee-for-service when we report back to the federal government. It's a really good question. They've all been good questions, actually. Going once. I liked when it stopped last time at 2. That was kind of cool. It was dramatic. Going twice. I'm pausing for drama. Pausing. Okay. Thanks, everybody. Thanks for staying late.